What are the physical exam findings in murmurs caused by HOCM, or Hypertrophic Obstructive Cardiomyopathy? Hello, I'm Dr. Habibi, and in this video, I want to explain heart murmurs in simple and understandable language, so stay with me. To review the characteristics of HOCM murmurs, we use the word script. S stands for site. The best place to hear the HOCM murmur is at the LSB, or left sternal border. C stands for character. This murmur is harsh, musical, and has a crescendo-decrescendo pattern. That means during systole, it rises and then decreases. R stands for radiation. This murmur may only be heard at the LSB, or sometimes it can radiate to the apex area. I stands for intensity. The intensity of this murmur is variable and depends on the severity of the gradient. P stands for pitch. This murmur is high-pitched and high frequency. T stands for timing. This murmur is systolic. That means it is heard between S1 and S2 as a crescendo-decrescendo murmur. Besides the characteristics of the murmur itself, there are some other features found in the physical exam. The first feature is paradoxical splitting of S2. This means the second heart sound is heard as a split. But first we hear P2, and then, with a delay, we hear A2. In normal individuals, following inspiration, which creates negative pressure in the chest, venous return increases, and as a result, the right ventricular volume also increases. The time it takes for the right ventricle to empty increases. That means, due to the delay in the closure of the pulmonic valve, P2 is heard later. In other words, P2 moves further away from A2, and physiological splitting of S2 occurs. But in patients whose left ventricular outflow is narrowed, like those with HOCM, the time it takes for blood to leave the left ventricle becomes longer, so the aortic valve closes later, and A2 is heard later. This is called paradoxical splitting of S2. The next characteristic is a loud S1. Because there is forceful atrial contraction, the first heart sound becomes louder. The next characteristic is an S4 gallop. The fourth heart sound is also heard at the end of diastole, just before S1. What is the cause of S4? Any factor that causes resistance during left atrial contraction, and the entry of blood from the atrium to the ventricle can lead to the S4 gallop being heard. There are two main factors that cause S4. One is ventricular hypertrophy, and the other is ischemia. And in patients who have LVOT obstruction, like in HCM, S4 is heard due to ventricular hypertrophy. If you found this part of the video helpful so far, please like it and share it with your friends. And if you don't want to miss my next videos, please subscribe. The next characteristic is palpation. In these patients, the PMI is increased and shifted to the left, and a thrill may also be felt. So, if we place our hand on the patient's chest during palpation, in cases where the gradient is high, we can feel the thrill. Additionally, due to the existing ventricular hypertrophy, the PMI is increased and shifted to the left. And the next characteristic is a double apical impulse. In patients with HCM, the LV area is divided into two parts, and there is a gradient between them. On palpation, you might also be able to feel the contraction of these two areas separately, which is called a double apical impulse. This means that during systole, when the left ventricle contracts, first the area proximal to the stenosis contracts, and then the area distal to the stenosis, or the LVOT. And we can feel this as a double impulse, or double apical impulse. In some cases, there's even a triple cadence, meaning 3 impulses. The next characteristic is in the arterial pulse. In normal individuals, the arterial pulse has an upstroke and a downstroke. But in people who have this condition, the arterial pulse changes. The first part becomes sharp and pointed. It's like a spike or a spear. And the second part has a dome shape, which we call a damp. So the pattern it creates is called a spike and damp pattern. What causes the spike and damp pattern? This sharp and pointed part is due to the contraction of the left ventricle at the beginning of systole, when the outflow tract hasn't narrowed yet, and blood easily leaves the left ventricle and enters the aorta. But in the middle of systole, because of the existing hypertrophy, the left ventricular outflow tract becomes narrower. This creates the damp pattern. Therefore, the arterial pulse in the disease that prevails is a biphasic pulse, meaning a pulse with a double peak. That is, there are two peaks in systole, with the first peak being higher than the second. The last feature is in dynamic auscultation. HOCM is size dependent, meaning any factor that reduces the size of the left ventricle causes the walls to come closer together, which increases the gradient. Due to the increased pressure gradient and increased turbulence, the intensity of the murmur also becomes more pronounced. Conversely, any factor that increases the size of the LV, since the distance between the walls increases, the pressure gradient decreases, and the intensity of the murmur also lessens. That's why, after standing up or performing the Valsalva maneuver, since the size of the heart decreases, the pressure gradient increases, and the intensity of the HOCM murmur also goes up. But after performing the squatting maneuver or hand grip, clenching the fists, since the size of the LV increases, the intensity of the murmur decreases.